So I'll be talking about imaging, doing when to and how to image patients who are coming with query infected cardiac leads and devices. So when we are talking, we'll be talking about prosthetic valves, surgical aortic valves, post-Bentall, septal occluder devices, cardiac implantable electronic devices, LVADs and BiVADs. So So the role of imaging is not only to diagnose the infection, it is also to look at the location, the extent of the involvement. If it is about prosthetic valve, to see whether how is the movement of the valve affected, whether it is leading to regurgitation or stenosis, look for any sequelae and complications and help guide the management, be it medical or surgical. So, as we all know, transthoracic echocardiography is the first line approach, and you may follow it up by transesophageal echocardiography when you think that the clinical suspicion is high and your transthoracic echocardiogram is normal. So there is a complementary role of both of these investigations whenever you have an uncertain diagnosis. Besides this, you can also add multi-slice CT, FDG PET, and MRI. MRI has a very, very limited role, so I'm not going to talk in my presentation about it. So let's first talk about the prosthetic valve in endocarditis, which accounts for around 1/3 of the patients, or of all patients of infective endocarditis, which has a very high mortality rate. And this is something you need to pick up early and fast, because this will lead to many complications. Not only it would lead to valvular regurgitation and obstruction, or it could also lead to perivalvular dehiscence, abscess, pseudoaneurysm, or fistulae. So many complications which may in fact mandate a repeat surgery beyond removing the valve also. So as we all know, the Duke's criteria are used for making the diagnosis of endocarditis, but it's important to remember when we are talking about prosthetic valve, the Duke criteria are less useful because we are relying a lot on echocardiography and a lot on isolating the microorganisms. Because in these patients, the echocardiography is hampered by the scattering artifacts because of the metallic component of the prosthetic valve. And then there may be organisms which may not immediately show up in your initial scan. So this will delay your antibiotic treatment. So it's important when you have a strong clinical suspicion, you add either MDCT or PET or MRI, as the case may be. So I'll be taking you through your journey, which investigation to, order and when. So let's begin again with the transthoracic echocardiography and transesophageal echography. Like I said, there are the initial investigation performed as soon as you suspect infection. And transesophageal can be added onto TTE once you think the clinical suspicion is strong and the TTE is negative. So you make a diagnosis, you look at, this is also good for follow-ups and also to see the response to treatment. So the indications are class 1B and beyond. So now the question arises, when do you need these, the newer non-invasive imaging techniques beyond thoracic and transesophageal echocardiography? So this is a paper which talked about 500 patients, and they found that the acoustic shadowing and the reverberation because of the metal of the prosthetic valve led to hampered imaging in these patients, and they found that transesophageal echocardiography understandably was more sensitive compared to transthoracic echocardiography. However, still 18% of the vegetations and 14% of the periannular extensions were missed by even transesophageal echocardiography, and this led to a delay in incorporating the antibiotics on time. So you look at this TE image. So this is a systolic image. So the anterior side of the valve is leading to a lot of reverberation artifact posteriorly. So it is only during the diastole, when the valve is closed, that you can see that there is a mass which is just below the valve ring. So these are the sort of artifacts which you may see when you are seeing the prosthetic valve. Beyond echo, you can do a cinefluoroscopy, which is very good for patients for follow-up and in patients in whom you find high echocardiography gradients. So what we see on the valve is the valve movement. We look at the opening angle, which is usually less than 20 to 30. Nuclear imaging is another modality which can be added. So FDG PET can be added, and it can be useful to reduce the misdiagnosis of possible infective endocarditis based on the due criteria. So also, what is important is it helps you identify the infection early and start your antibiotic prior to development of the structural changes. And also it helps you pick up peripheral emboli and metastatic infection. But important thing is, remember, you have a special resolution limitation with FDG PET. So smaller emboli less than 5 mm may be missed on FDG PET. So this is a paper which had talked about FDG PET and combining it whether with a CT angiography or not. So patients, all of them underwent PET. However, 76 out of the 92 had only cardiac CT along with the FDG PET. So what they found was the sensitivity and the specificity, which was 86 and 80% increased to 91 and 91% when the CT angiography. So what they found was essentially that the PET CT combined yielded the highest diagnostic performance and provided additional diagnostic benefits. This is something which Jahan has also talked about. So the inadequate suppression, the preparation of the patient is very important in the FDG PET. So false positive may be there. Also, if the patient has had a recent surgery, then again you may have, because of the edema, there may be an increased FDG uptake. So that has to be kept in mind while reading it. So that is why the guidelines, the ESC guidelines for 2015, they suggest using FDG PET only for suspected prosthetic valve endocarditis when the patient has had the valve placement later than 3 months earlier. So also it is useful only for suspected prosthetic valve endocarditis and only when initial testing remained inconclusive. Talking about MDCT, it is very useful investigation in conjunction with echocardiography or PET to pick up periannular complication. This is something, remember, which will not pick up infection per se. It will pick up the mechanical complications which have come as a result of infection. So what you will see is the periannular complications, extensions, fistulae. It can also give you aortic assessment for surgical planning. If the patient needs a coronary assessment, you can have a simultaneous coronary assessment of these patients. Lung septic infarcts, splenic infarcts, valve integrity, and ventricular function are something you can, this entire information you can get in one go on CT. But remember, this is only for structural information. You do not see infection per se on CT. You suspect because of thickening and all the infection, but you need to have something like PET to make a diagnosis of it. So this is again that paper which I talked about. So adding CT to the transesophageal echocardiography actually improved the diagnosis, and specifically it was found that it was specifically useful in patients who had periannular complications. So adding CT in patients who have these periannular complications makes sense when the patient is having positive PET. So this is an example of how do you make this? This cine should work. Anyway, so what I wanted to show was that the valve movement can be seen. You can see periannular count. So this is a patient who had normal echocardiography, but the PET actually showed an increased metabolic activity. Can you go back to the last slide? Okay, fine. So this patient had abnormal PET, but normal echocardiography. So you can see the periannular complications, the aneurysm arising from the LVOT, from the ascending aorta can be seen, the valve motions can be seen. You can see the entire, whether it is preserved, whether the aorta, is there any dehiscence which can be picked up. So all these information can be obtained on the CT. Besides also seeing, this was a 52-year-old female, besides also seeing the coronary arteries in this patient. Also, you can differentiate between other differential diagnosis. So you can differentiate between vegetation, pannus, and abscess also based on the location of the soft tissue and the density on the CT. We can tell whether it is pannus. This is a pannus in the bioprosthetic valve. So all the more better to see bioprosthetic valve because you don't have metallic artifacts which will hamper visualization of the soft tissue. And this is a patient who has got thrombus. So the density is less. So this is more of a thrombus rather than a pannus. So complementary PET and CT. So this, you can see, this is This is an aneurysm which was there, but you can see that on the PET there is no enhancement. So this tells us that this aneurysm actually is not infected. So, there is a role of complementary PET and CT in certain situations. So these are the guidelines. So if you have a possible infective endocarditis but high clinical suspicion on echocardiography, either repeat echocardiography, you may add PET CT or add a multi-slice CT as the case may be. So if you are having paravalvular complications or you're suspecting morphological complications, add cardiac CT and do also look for imaging for the embolic events. And like I said, when we talk about imaging, FDG PET is advisable only if the prosthesis was implanted for more than 3 months to prevent edema from giving you a false result. So few slides about device-related endocarditis, again very dreaded, but it is important to remember that transesophageal echocardiography will be, again, just like your prosthetic valve, the first line of investigation. However, the sensitivity will decrease. Small vegetations are something which you can miss. Difficult to differentiate edema and hematoma on echo and in patients with CID and with LVADs, portions of the devices, the distal portions of the devices may not be accessible. Then there are problems of thrombus or fibrous sheet, which may encase the lead, which may be mistaken for lead infections. And also remember, many of the masses, up to actually 14% of the masses which may be seen on leads actually may not be infectious. So just finding this mass and equating it to infection will not be all right. So if I talk about CT angiography here has very, very limited role because there are a lot of artifacts produced because of streak and beam hardening. So some indications would be like generator pocket infection if the patient is having, then one may see fluid surrounding the device with ring enhancement or a fat stranding. For LVAD driveline infections, for picking up larger abscesses near the leads, and for assessing complementary coronary assessment in these patients. FDG PET is very good, has got a high sensitivity and specificity, and is very useful in inconclusive cases of possible lead infections. And it is actually the investigation of choice for evaluation of pacemaker pocket infections. Also, it can pick up distal infections also. However, it is important to differentiate that, the inflammation from the infection. So what they say is there are papers the recent papers have talked about that if the infection uptake is focal at the infection site, it is infection. And if it is homogeneous, then it is more suggestive of inflammation. So they now say it is possible to differentiate inflammation from infection using FDG PET. This is limitations which we have already talked about. Preparation is a big issue. So this is an example. So 70-year-old male patients showing increased uptake at the site of pacemaker. So this is a pocket infection, and this is one of the most common type of infections, and you have to extract the entire lead, entire device because of this infection. LVAD, again, echocardiography and CT. Echocardiography is a good investigation. However, distal vessels distal part of the device may not be well seen. CT has no role because of artifacts. PET CT is the way to go. So I would like to just summarize by saying for prosthetic valve infections, the first line obviously is your echocardiography. Whenever you have suspicion, you may add a CT angiography or the FDG PET as the case may be. Whereas for the suspected CID and LVAD infection, CT angiography has no role. So echocardiography, if you are suspicious, add FDG PET, and that will further confirm your diagnosis. Thank you very much.